Olá, seja bem-vindo à cobertura da TV SBU ao 16º Congresso Internacional de Uro-oncologia, onde recebemos diversos palestrantes internacionais e nacionais de muita relevância no tema. Eu sou Vinicius Meneguette, urologista de São Paulo, e recebo aqui comigo, e tenho a honra de receber aqui comigo, o professor Howard Sandler, que é Chair de Radiation Therapy of the Cedars-Sinai Hospital, Los Angeles. We'll go in English after the introduction. Welcome, Professor.
Thank you for having me. I'm happy to be in Sao Paulo at this conference.
Good. We are going to talk about some themes in the interface of urology and radiation oncology. And the first I would like to bring for our talking is what is better for the locally advanced prostate cancer? Radiation therapy plus androgen deprivation therapy, surgery plus lymphadenectomy, or we can change between both sides based on each case?
I'm a radiation oncologist, so I bring that perspective often in the management of prostate cancer. We have multidisciplinary discussions where urologists and radiation oncologists each meet with patients, try to learn about their preferences and values to help them with their decision making. In general, the more locally advanced the case, I think the less likely that surgery alone is a curative option. So the more advanced prostate cancer cases, I often recommend radiation and hormonal therapy. Now, I will say that in some cases, surgery offers an advantage. For men who have difficulty urinating because of an enlarged prostate, radiation's not going to help that, and surgery might be a better option for a man with baseline urinary dysfunction. And in a small subset of patients, surgery alone might be curative, leading to an undetectable PSA without any need for adjuvant hormonal therapy or radiation. So it's possible that in some surgical cases, the use of hormonal therapy can be avoided. But on average, I think most patients have the best cure, quality of life benefit with a radiation and hormonal therapy approach for locally advanced disease.
All right, and we have a very large discussion on the congresses and between clinical oncologists, radiation oncologists, and urologists about the time of androgen deprivation therapy. What's your practice on androgen deprivation therapy nowadays?
Yeah, the discussion at the conference has been fantastic, with many topics being well discussed, including the role of hormonal therapy and the duration of hormonal therapy and the drugs that should be used. So for locally advanced non-metastatic prostate cancer without lymph node involvement, I think the level of evidence pretty strongly favors what we call long-term hormonal therapy. Long-term hormonal therapy is generally androgen deprivation therapy with agents like leuprolide for 18 to 24 months in the US. I think you could potentially broaden that out to 18 to 36 months. I don't think that there's good evidence that hormonal duration of less than 18 months is adequate. It's a long time to be on hormone therapy. Attempts to shorten the duration of hormonal therapy to 6 months have not been successful in locally advanced. So for men who truly have locally advanced disease and a substantial risk of dying from prostate cancer, I recommend 18 to 24 months of leuprolide.
Good. And changing from prostate cancer to kidney cancer, I would like to bring up a new theme on the treatment of the small renal lesions, that is radiation therapy as primary treatment for some lesions. We talk about long time from renal sparing surgery and from ablation therapies, and now we start to talk about radiation therapy in this subset of patients. Tell us your experience on the theme.
Yeah, I'm really excited and pleased to be able to speak about the role of radiotherapy in the primary management of kidney cancer. It's not something that 5 years ago I would have imagined that we would be speaking about at a multidisciplinary congress like this. Of course, the gold standard for kidney cancer is surgery, with nephron-sparing surgery whenever possible. So for most patients, that's what we're talking about. However, there's a subset of patients who might not be surgical candidates and still have clinically important kidney cancers. And radiation therapy has emerged as one of the options. Now, the way this has happened is because of improvements in radiation techniques. Small series from different hospitals were suggesting that radiation gives pretty good local control. So there was this hint of evidence. The second step was a large multi-center registry was put together. So small series from different hospitals were accumulated into a large retrospective series suggesting pretty good local control. And finally, from Australia, a prospective phase 2 study looking at T1A, T1B kidney cancers, all biopsy proven, showed 100% local control, and which is extraordinary. And whether that will hold up over time or not remains to be seen. It's not been randomized to the gold standard of partial nephrectomy, but it's very encouraging. And for non-surgical patients, I think radiotherapy using SBRT focused techniques are within the standard of care today. Now, compared to ablative procedures, I think radiation is not a bad option, especially for T1B tumors or those that are greater than 4 centimeters, because I think ablative techniques have a relatively high local failure rate for T1B lesions. I'm not saying radiation should take over from ablative techniques, but maybe for the larger T1 tumors, SBRT is an option for non-surgical candidates today.
It's quite impressive, 100% of response. I understand this makes a huge sound on the urological and oncological community.
Well, 100% is pretty good results. I am speaking later on in the Congress about this, and I will discuss some limitations in that 100% data. But regardless, there's a lot of enthusiasm in the radiation oncology community for SBRT for primary management of kidney cancer.
And I'm looking forward to see your speech on kidney cancer and
Thank you.
news.
It's great.
Thank you very much, Professor Howard, for having us on this great talk. And now in Portuguese, I will end our video. E você gostou também do nosso conteúdo e da cobertura do 16º Congresso Internacional de Uro-oncologia? Se gostou, siga o Portal da Urologia no Instagram e todas as nossas mídias para acompanhar mais notícias como essa e outras entrevistas de temas muito relevantes com convidados de importância nacional e internacional. Um grande abraço.